Hello, I wanted to talk about a couple of patients, siblings that we saw in our immunohematology clinic. They were referred to our clinic by Adam Duvall, who was a MedPeds resident who saw them on the adult side and said, you should come to this diagnostic clinic for us. So here's everyone who's been involved. The first patient is a 53-year-old male who was seeking somewhere around his fourth or fifth opinion about his bone marrow failure and getting consultation for possible transplant. His story started probably back in 1997 when he had a low white blood count that not much was done. And then he officially saw a hematologist in 2010 after he had a CBC that showed that low white count. Hemoglobin was normal at that time. He had a workup for CML, which was negative, and he gradually progressed over 3 years to more pancytopenia. So he presented again symptomatic in September 2013 after he had a biopsy that I'll show you in a minute. But he was admitted for right lower extremity cellulitis and sepsis, and he began requiring red blood cell transfusions. He probably had about 20 over the course of a couple of years. He again presented again in November 2013 for symptomatic anemia. Bone marrow that was done in June 2013 showed trilineage hematopoiesis. This one showed really low cellularity, less than 5%. There was no dysplasia there, but prominent reticulin fibrosis was seen and increased interstitial lymphocytes. A repeat marrow, he's had several throughout 2013, had very similar findings, but the biopsy showed anywhere from 0 to 85% cellularity, depending how they were sampled. So it was really a patchy hypercellularity. Studies to look for MDS and leukemia were negative. He was ANA positive. On his exam, he really was well appearing. But in retrospect, and this wasn't identified until more recently, is that he did have evidence of livedo racemoso in his legs. I think it was generally burned out, and he just, if you look at him, you can see some laciness on his calves, but he just has a lot of hemosiderin atrophic skin on his legs. A repeat marrow in 2013 showed, again, 20% cellularity and fibrosis. He was ultimately diagnosed as a working diagnosis with aplastic anemia and treated as such. He was treated on maintenance with cyclosporin after receiving ATG. He trialed off of it after a while, but had to restart due to falling red blood cell counts. Getting back into his history a little bit more, he does endorse that he had lower leg skin rash and ulcers above his ankle since his late teens. He actually had to give up downhill skiing because the boots irritated his leg so much. But really no other huge constitutional symptoms. There was some, we don't have records of the episode of dermatomyositis as a child. There was a history of splenomegaly as an adult, but that resolved. And he's had a long-standing history of eczema, which runs in the family. Around the same time in 2013, his brother presented with leukopenia, and there's some distant family members that I'll show on a pedigree in a minute with MDS. His mother had multiple miscarriages. I don't know exactly how many at this point. He was a tool and die maker and did have exposures to benzene and had quite a few toxicology studies done, and he didn't have any heavy metal accumulation. So this is a picture showing the patchy cellularity in his bone marrow. You can see some areas that were almost exclusively fat and others that were quite cellular. His bone marrow showed the megakaryocytes and then primarily myeloid precursors and maturing myeloid cells, but very few erythroid cells. Here's a higher magnification showing a lot of the myeloid elements, but very few erythroid precursors. There was generally increased lymphoid infiltrates in his bone marrow too. And what struck our hematopathologist was the reticulin stain, which having this much reticular fibrosis seemed unusual to them. There was just faint collagen fibrosis on trichome staining. So here's another view of the reticulin fibrosis, and it reminded our hematopathologist of other bone marrow failure disorders such as dyskeratosis congenita. His labs, when we evaluated him, showed a mildly low lymphocyte count, and specifically CD4 lymphocytopenia, low B cells, and moderately low NK cells. He had IgM deficiency and a slightly low IgA as well, normal tetanus and other titers. His brother was seen primarily for the purposes of getting him worked up for his bone marrow failure, and we were going to do whole exome sequencing. We got his records from his hematologist. They were seen at 2 different institutions. And at 52 years of age, 3 years ago, he had a low white blood count during infection. The neutropenia persisted. They worked him up for cyclic neutropenia, did a bone marrow on him because of his brother's history, and he had normal cellularity with focal fibrosis that looked very similar to his brother. Lymphoid aggregates were there, and the reticulin staining was positive. But he had decreased myeloid granulocytic precursors. His history was a little bit more interesting for infections, but no other vasculitic sort of diseases. He had repeated Aeromonas hydrophila infections. He liked to go swimming in a lot of interior lakes in Michigan, and he said if he ever had a cut on him, he would get an infection. He actually been admitted several times for IV antibiotics for cellulitis. And he works as a refrigerator salesman. So his labs, when we saw him, he actually had a very low count of ANC of 0.1. His lymphocytes were generally okay, and he showed IgM deficiency with normal IgA and IgG. So we took him and his brother and his mother as a trio for whole exome sequencing, and we found that both had compound heterozygotes for CECR1 gene variants. And these are, as far as I can tell, novel variants. They are present in the exact database exactly once out of 33,000 people. And they also both had a filaggrin gene mutation, which is a common mutation in the population that predisposes to dry skin and eczema. So here's the pedigree. They have one brother that we haven't yet evaluated who's been healthy. His mother, who we sequenced, had the leucine 188 proline change in the filaggrin mutation, but really has been healthy. Further back in the family, the myelodysplasia was in 2 individuals, the grandparents here, who are both in their 90s before they developed myelodysplasia. There's other people on this side of the family with leukemia that we don't know the exact relation or diagnosis. So we did confirmatory testing in Dr. Hirschfeld's lab, and both of them were very deficient. They've subsequently are beginning to get worked up to start anti-TNF therapy, have had MRAs and MRVs of the head that have been normal. They have had no clinical history of strokes. So in summary, 2 brothers with different cytopenias were found to be deficient. In retrospect, one began manifesting signs probably with the dermatomyositis as a child and the skin ulcerations and livido on his lower extremities. So what this adds, I think, is that we can see either red blood cell or other cytopenias, particular reticular marrow fibrosis in these individuals, and confirms that we see low IgM levels, recurrent Aeromonas hydrophila infections, which can be common in immunocompromised individuals, were seen in one of our patients, and 2 novel mutations were identified. So I want to thank the people who participated in this. Charlie Ross reviewed the bone marrow biopsies with me. Amy Vanderwood and Dr. Chamarthy were the primary hematologists who followed these individuals before seeing us until they came to our immunohematology comprehensive program clinic, where we evaluate individuals with bone marrow failures, primary immune deficiencies, neutropenias, and lymphoproliferative disorders. Thank you.